Good morning, everyone. Today, we're focusing on bradyarrhythmias, especially the dangerous high-grade AV blocks. Our mission is rapid recognition, swift intervention, and safe disposition. Picture a patient whose heart rate falls below 50 BPM. In high-grade blocks, Mobitz 2 and complete heart block, the atria and ventricles lose their handshake. Causes range from an acute inferior MI, starving the AV node of blood, to medication overdoses or even digoxin toxicity. Patients may faint, feel fatigued, or collapse in a Stokes-Adams attack. Our first job, maintain perfusion until a pacemaker can take over. We begin with the ECG. In third-degree block, P waves march independently of QRS complexes, constant atrial rate around 70 to 90 BPM, escape rhythm pacing ventricles at 30 to 60 or even as low as 20 to 40 BPM. In Mobitz 2, PR intervals are fixed, then suddenly a beat drops. Contrast that with Mobitz 1, progressive PR prolongation before a dropped beat, which is usually benign if asymptomatic. Next, we assess stability. Check blood pressure, mental status, skin perfusion. Hypotension, chest pain, or altered mentation defines unstable bradycardia requiring immediate treatment. A stable patient buys us a bit of time, but still demands prompt planning. A focused history reveals medication culprits, VU blockers, calcium channel blockers, digoxin, and warns of an acute MI via chest pain or ischemic signs. Ask about prior conduction disease or pacemaker placement, and listen for syncope or near-syncope episodes suggesting a dangerously slow escape rhythm. On exam, check the pulse, slow, regular, or sometimes variable. Look for canon A waves in the jugular veins, atria contracting against closed tricuspid valves, and listen for variable S1 intensity. Cool, clammy skin and confusion signal poor perfusion. Rapid labs guide us to reversible causes, electrolytes like potassium and magnesium, digoxin levels, and troponin if we suspect an MI. A quick chest X-ray can confirm pulmonary edema or show device position, and later an echo tells us about EF and structural damage. Always differentiate. A sinus bradycardia has P waves tied to each QRS. First-degree AV block just prolongs PR. Wenckebach patterns often need no pacing if asymptomatic, but Mobitz 2 and third degree are emergencies. Assume that wide complex bradyarrhythmia is an infranodal block that may not respond to atropine. For unstable high-grade block, administer atropine 1 mg IV, repeating to a maximum of 3 mg while you prepare for transcutaneous pacing. Apply defibrillator pads in the anterior-posterior position, start pacing at 80 BPM, and titrate current until you see pacer spikes capture the ventricle. Sedate the patient. Pacing can be painful. If pacing isn't immediately set up, begin chronotropic infusions, dopamine or epinephrine, to keep the heart beating until you can place a transvenous pacer. Don't forget to address the root cause. Reperfuse that inferior MI, shift electrolytes back into balance, or reverse drug toxicity. Even if a patient with high-grade block appears stable, we rarely delay pacing. Mobitz 2 and complete heart block almost always require a pacemaker. In Mobitz 1, if it's drug-induced or vagal, we can observe and remove the offending agent, but we remain ready to pace. Disposition is straightforward. ICU admission for any high-grade block, with cardiac monitoring and pacing support. Most will need a permanent pacemaker. Consult cardiology and electrophysiology early. If block followed an inferior MI, watch for resolution post-reperfusion over 24 to 48 hours, but keep that pacemaker on standby. Educate patients. Avoid AV nodal blockers until cleared, and if they've received a pacemaker, teach wound care and device precautions. In summary, high-grade AV block is a race against time. Recognize it on ECG, assess perfusion, stabilize with atropine, pacing, or infusions, and secure a pacemaker for definitive treatment. Thank you for your attention. Let's now discuss your questions and any challenging cases you've encountered.